Far end? Far
Yeah,
left?
I'm left-handed.
Never been in my left.
You. Hi.
Hello.
Oh, I guess I'm in your seat, is it? There we are.
It's quite all right.
Dennis,
Hi.
you're on.
The Subcommittee on Health will reconvene, and our next panel is on employer and employee views. I think you're all, hopefully the panel's, I'll wait till you get seated here a minute. Let me introduce the panel. From my left is Kelly Conklin. Mr. Conklin, who is the owner of Foley Waite Custom Woodworking, Main Street Alliance. And then we have John Ahrensmeyer, who's founder and CEO of Small Business Majority. We have Gerald M. Shea, who is the assistant to the president of the AFL-CIO, Dennis Rivera, who is the healthcare chair for the SEIU, John Castellani, who's president of the Business Roundtable Institute for Corporate Ethics, John Shells, who is senior vice president for the Lewin Group, and Martin Reiser, who is manager of government policy for Xerox Corporation, I guess representing the National Coalition on Benefits. And, you know, we asked you to speak for about 5 minutes. Your written testimony becomes part of the record, and then we'll have questions from the panel. So I'll start with Mr. Conklin. Thank you for being here.
Thank you, Chairman Pallone, Ranking Member Deal, and other members of the committee for inviting me.
Mr. Conklin,
Yeah.
I see the green light is on, but you got to push that mic closer to your,
Okay.
closer to you, almost like on top of you.
Okay, how's that?
That's good.
Okay. Thank you, Chairman Pallone, Ranking Member Deal, and other members of the committee for inviting me to appear today. My name is Kelly Conklin, and I co-own with my wife, Kit, an architectural woodworking business in Bloomfield, New Jersey. My purpose today is to explain how the House Tri-Committee's health reform proposals might affect small companies like ours. To start, I think the draft legislation is right on target. I believe it will receive broad support in the small business community. Before I go any further, let me provide some background. My wife and I opened Foley Waite in 1978 in a 700-square-foot shop in Montclair, New Jersey. In 1985, we expanded, hired 4 employees, and started offering health insurance. The premiums were about 5% of payroll, and we paid it all. Today, we employ 13 people, occupy 12,000 square feet of space, and serve some of the most influential people in the world. And we fork over $5,000 a month in health insurance premiums, close to 10% of payroll, and one of the largest single expenses in our budget. Practically speaking, we offer coverage to attract and retain skilled employees. But like the majority of small companies, we do so because it's the right thing to do for our workers. And we don't offer coverage. If we don't offer coverage, we're just passing our obligation and our share of the cost onto someone else. Cost is by far the single most important driver in making basic decisions regarding health care. That applies whether it's a small firm like mine or the United States Congress, and no system that tends to dance around the cost issue can succeed. April is a month I dread, not for taxes, but for health insurance renewal nightmares. Every year is worse: unpredictable rate hikes, unaffordable premiums, an administrative tangle that is our system. In 3 years, we've had 3 different insurance companies. Most recently, Horizon Blue Cross Blue Shield raised our rates 25%. Now we have HealthNet. That means new primary care physicians, and for my wife, who has a chronic illness, a new doctor who knows nothing of her medical history. It's very frustrating. There are no quality, affordable health care options available for small businesses. In reading the discussion draft, it is apparent the committee is determined to control cost. Responsible employers understand we will all be better off in a system where employers and individuals contribute a reasonable amount toward ensuring our common health and well-being. That's why I support the draft provisions requiring employees and individuals to pay their fair share. For too long, the small business community has paid too much for too little. We sacrifice growth, financial security, and the peace of mind of our employees and their families in the name of protecting private insurers from meaningful competition. The private health insurance market has failed to contain costs, enhance efficiency, or improve outcomes. It fails to provide coverage to millions. Half measures, warmed over, more of the same second chances for the health insurance industry won't fill the yawning gaps in our patchwork coverage. We need a guarantee that individuals and small companies will have real choices and affordable coverage options. I commend the committee for including a strong public health insurance option in this legislation. With a public option, small businesses will have leverage, real bargaining power, and guaranteed backup at greater transparency. Most importantly, by creating genuine competition and restoring vitality to the market dynamic, this proposal will bring about the kind of broad-based changes in the private insurance industry Main Street is clamoring for. For a small business like mine, bringing down health insurance premiums can be the difference between growth and sitting tight. 2 years ago, we were interested in buying a building. It represented growth potential, financial security, and long-term equity. We were looking at around $5,000 a month in mortgage payments as opposed to our rent of around $3,500. If our health insurance premiums had been closer to our rent and not the future mortgage, we might be in that building today. We work in a competitive marketplace. All the time, there are new competitors looking to take business away. We find savings, improve efficiency, invest in equipment and personnel. That's how it is for us, and that's how it will be for the health insurers if a public option is available. Transparency is critical. It's time for the insurance companies to come clean and in plain English explain where our premium money goes, to say up front what's covered and what's not. It's time to put a halt to cost containment by denial, co-pays, and hidden charges. The draft discussion addresses this need by creating a health insurance exchange to offer real coverage choices that allow us to actually know where our premium dollars are being spent. We can provide access to both preventative and therapeutic care for everyone. We are encouraged by the provisions reforming common practices in the current insurance market. Ending lifetime and annual benefit limits, discriminatory coverage, and rating policies, and creation of a basic benefit are all important and necessary parts of a complete reform package. These are full measures designed to provide real relief. If enacted, they will represent a watershed for American health care and a godsend to the small business community. This committee, working with its counterparts to develop the tri-committee proposal, has done yeoman's work taking on and meeting an extremely complex set of issues. I will not be alone in supporting this extraordinary effort. I am a member of the New Jersey Main Street Alliance, a coalition of over 450 small businesses working for health reform that will finally give us access to quality health care we can afford. I have canvassed small businesses, and when I say, and we support a public option, they take the pen out of my hand, and the New Jersey MSA has a new member. Small businesses have sought your leadership, and with this document, you have delivered. Now the real fight begins. We need you to enact this proposed legislation and bring about health reform that works for us and our employees this year so we can do our part for economic recovery. Thank you, Mr. Chair.
Thank you, Mr. Conklin. Mr. Ahrensmeyer.
Thank you, Chairman Pallone, Ranking Member Deal, and members of the committee. Small Business Majority appreciates this opportunity to present the small business perspective on the House Tri-Committee Draft Health Care Reform Plan. We support the effort to move this legislation through Congress expeditiously, and thank you for bringing a proposal forward in such a timely manner. Small Business Majority is a nonprofit, nonpartisan organization founded and run by small business owners and focused on solving the biggest single problem facing small businesses today, the skyrocketing cost of health care. We represent the 27 million Americans who are self-employed or own businesses of up to 100 employees. Our organization uses scientific research to understand and represent the interests of all small businesses. I've been an entrepreneur for more than 20 years, including 12 years owning and managing an internet communications company. Together with the other senior managers in our organization, we have a total of 70 years running successful small businesses ranging from high-tech to food production to retail. We hear stories every day from small business owners who can't get affordable coverage and for whom health care is a scary, unpredictable expense. Louise Hardaway, a would-be entrepreneur in Nashville, Tennessee, had to abandon her business dream after just a few months because she couldn't get decent coverage. One company quoted her a $13,000 monthly premium for her and one other employee. Others, such as Larry Pearson, owner of a mail-order bakery in Santa Cruz, California, struggle to do the right thing and provide health care coverage. Larry notes that, quote, "The tremendous downside to being uninsured can be instant poverty and bankruptcy, and that's not something my employees deserve." Our polling confirms that controlling health care costs is small business owners' #1 concern. Indeed, on average, we pay 18% more than big businesses do for health care coverage. An economic study that we released earlier this month, based on research by noted MIT economist Jonathan Gruber, found that without reform, health care will cost small businesses $24 trillion over the next 10 years. As such, we are pleased to see that the House bill addresses key cost containment measures such as expanded use of health IT, transparency, prevention, primary care, and chronic disease management. Our polling shows that 80% of small business owners believe that the key to controlling costs is a marketplace where there's healthy competition. To this end, there must be an insurance exchange that is well-designed and robust. We are very pleased that the committee's bill proposes a national insurance marketplace with the option for state or regional exchanges that adhere to national rules. Moreover, we are encouraged by the committee's proposal that there be standardized benefit packages along with guaranteed coverage without regard to pre-existing conditions or health status, a cap on premiums and out-of-pocket costs, and marketplace transparency. We understand that a balanced set of reforms will require everyone to participate. 66% of small business owners in our recent polls in 16 states, for which we released preliminary data this week, support the idea that the responsibility for financing a healthcare system should be shared among individuals, employers, providers, and government. It should be noted that respondents to our surveys included an average of 17% more Republicans at 40% than Democrats at 23%, while 28% identified as independent. According to the results of the economic modeling done for us by Professor Gruber, comprehensive reform that includes even modest cost containment measures and a well-designed structure for employer responsibility will offer vast improvement over the status quo. A system with appropriate levels of tax credits, sliding scales, and exclusions will give small businesses the relief they need, potentially saving us as much as $855 billion over the next 10 years, reducing lost wages by up to $339 billion, and restoring job losses by up to 72%. We are very pleased that the committees have addressed some of the affordability concerns of the smallest businesses. Professor Gruber has modeled specific scenarios described in detail in our report, and we look forward to working with you to ensure the best balance between the need to finance the system and our ability to pay. Finally, another issue of great concern to us is the unfair tax treatment of the 21 million self-employed Americans. Under the current tax code, self-employed individuals are unable to deduct premiums as a business expense and are required to pay an additional 15.3% self-employment tax on their health care costs. We encourage that this inequity be rectified in the final bill passed by the House. In closing, health care premiums have spiraled out of control, placing our economy and the fortunes of small business in peril. Health care reform is not an ideological issue. It's an economic and practical one. We are encouraged by the overall approach of this bill and look forward to working with you to make it a reality this year. Thank you.
Thank you, Mr. Ansmeyer. Mr. Shea.
Congresswoman Capps, I really appreciate the opportunity to share the views of the AFL-CIO on this critically important issue. And I want to start by saying a hearty congratulations on producing a very good draft bill. I think you really responded to what the American people have asked for. And we look forward to working with you over the coming weeks to get that bill enacted. You've decided to build health reform based on the current system, therefore based largely on the employment-based system, since that's the backbone of our health coverage and health financing. And I want to direct my remarks to that today. And I hope that the experience I bring, which is the experience of unions that bargain benefits for 50 million workers each year, will be of some benefit to you. And the main thing I have to say is, if you're going to proceed down this path, and we certainly support it, then job number one is stabilizing employment-based coverage. It has proved remarkably resilient in the face of high cost pressures, but it is in fragile shape today. From 2000 to 2007, we lost 5 full percentage points on the number of 18 to 64-year-old working Americans who were covered, and the underinsured rate, people who have insurance but really can't afford to get care under it, shot up from 16% to 25% in the last 4 years. So despite the fact that it's still hanging on, employment-based coverage is really eroding very rapidly. And to stabilize that coverage, we would suggest that you focus first of all on costs, secondly on having everyone involved in coverage and in the system, and thirdly, and I don't mean these in rank order, they're really just all important, thirdly, reform of the delivery system. Let me start with the participation because in some ways that's the simplest. If you're going to base this on employment-based coverage, we think it makes simple sense, as you've done in your bill, to require that everyone, every individual participate and take responsibility to some extent, certainly responsibility for their own health status, and every employer to participate. And that is included in your bill. And the benefits of this are simple. It helps bring people into the system. It does stabilize the employment-based coverage. It helps reduce the amount of federal tax dollars that you have to spend because everybody who's covered by an employer plan will not be dependent on monies that you have to raise and put into this bill for subsidies. It levels the playing field between employers who now who do provide and those who don't. And there are really just 3 categories of workers in terms of their insurance coverage. The vast majority, as you know, get insurance coverage at work. Some 92% of the employers at 50 or above workers provide health insurance. There are some employers who don't provide insurance, but certainly are well enough off to do that. The example of the lobby shop in Washington comes to mind. And then there are a group of low-wage, small employers who really need a lot of help to do this. Our suggestion is that everyone be included in this, no exemptions, because once you start exempting people, we think you're going to run into distortions in the marketplace as now exist. But we do think it's appropriate, as you have done, to provide tax subsidies for employers with low wage and small numbers of employers. And I would emphasize that we don't think there's just small numbers of employees. It actually is some measure of the financial stability or success of the firm that should be taken into account. Secondly, in terms of controlling costs, the most important thing we can do is to change the delivery system. If the Institute of Medicine estimate of 30% waste in the system is anywhere near correct, we could easily pay for health reform and cover all of the uninsured if we can get a substantial amount, not all of that, but a substantial amount of that waste out of the system. So that's the most important thing, and your bill includes a number of good provisions on that. We're working with your staff because we think they could be strengthened in a number of areas, but we think you've made a very good start. However, in the short term, that's really not going to do the job. You're going to need to do something else, and there are only 2 options in our view as to how to do this in the short term. One is to do it by regulation. You could do global budgets or set rates. And the other is to introduce competition into the marketplace that now doesn't exist. And you have chosen the idea of competition through a public health insurance plan, and we strongly support that. I would just point out that there's an additional advantage of a public health insurance program in that it can be a leader in reform of the system, as Medicare is now. I deal with a lot of employers and a lot of unions who've wanted to change the delivery system for the better over the past few years, but it wasn't until Medicare started to change their payment rates that this really started to happen. And then lastly, looking at the delivery system, I think, as I said, that there's plenty of money in it to pay for reform. But we're not going to get that money back very quickly. And some people are talking about having to pay for reform totally out of the current money of the system, which we think is just very unrealistic. We think you have to look outside for additional monies. And if you take the view that you've got to look inside, you may well get to the very dangerous territory of the Senate Finance Committee talking about taxation of benefits, which we think would be a disastrous approach. It's unfair to the people involved, since they already pay an arm and a leg, many of them, for health coverage, and it's unfair in terms of the inequities built into this. Workers who are older, groups that have families, groups that have more retirees will have much higher costs, and so there's, and then there is the simple political dynamic of this. If you wanted to throw a monkey wrench into public support for health reform, this would be the perfect way to do it, because in the process you'd really turn the apple cart upside down in employment-based coverage. Thank you, Mr. Chairman.
Thank you, Mr. Shea. Mr. Rivera.
Thank you. I'm chair of SEIU Healthcare, the 1.2 million healthcare workers who are committed to reforming our nation's broken healthcare system. We represent members like Pat DeJong of Levy, Montana, who works as a home care aide. Pat and her husband, Dan, were ranchers, but had a hard time finding affordable coverage and were uninsured when he was diagnosed with Hodgkin lymphoma in the year 2000. The medical bills piled up for Pat and Dan, eventually forcing them to sell the land they loved and that has been in Dan's family for generations. Dan succumbed to cancer and Pat remains uninsured. This is America. We can and we must do better for hardworking families like the DeJongs. Americans are ready to fix health care, and they know that this is the year it must happen. Now it's up to you to deliver, Pat and the millions who face the consequences of our broken healthcare system with a real choice of affordable, quality, private, and public healthcare coverage. SEIU 1.2 million healthcare workers in hospitals, clinics, nursing homes, and in homes and communities are at the bedside every day witnessing high-priced families pay for the delay and skip medical treatments. The uninsured are not just statistics. They're hard-working people, people such as Pat, who despite caring for those who cannot care for themselves, cannot afford health care coverage for herself. Your discussion draft includes many essential elements that will promote coverage and access, cost containment, and improve quality and value for American families. A strong public health insurance option is vital to ensuring consumer choice and access. The public plan will drive down the cost of insurance by competing with private insurance and lowering overall costs. Medicaid expansion. We support increase in Medicaid eligibility for families up to 133% of federal poverty. The discussion draft will also improve Medicaid payments to primary care practitioners to address concern about access to needed services by Medicaid beneficiaries. We caution the committee that safety net providers and systems must be protected to provide access and support to low-income communities and to maintain a mission that includes trauma care and disaster preparedness. Special payments to these facilities, such as the disproportionate share payments, must be maintained as coverage expands. In addition, essential community providers must be included in insurance plans that serve Medicaid beneficiaries and individuals eligible for health care credits. Health care reform needs to work for everyone, including the 4 million American citizens who reside in Puerto Rico, and we urge Congress to include Puerto Rico and all the territories in all parts of healthcare reform. SEIU is pleased to see that the committees recognize the need to improve the treatment of Puerto Rico and the territories on the Medicaid by increasing their caps and federal matching rates. While this is an important step in the right direction, it falls short of resolving the long-standing inequities in federal healthcare programs that have been hurting the people of Puerto Rico for decades. Share responsibility. Employers, individuals, and government must all do their part to make sure we have a sustainable and affordable system that covers everybody. For employers that do not provide meaningful coverage to their employees, they must pay into a fund. This pay-or-play requirement is necessary to ensure individuals can meet their responsibility to obtain affordable coverage. We especially support provisions to provide small businesses with tax credits and access to an insurance exchange to help them purchase coverage for their employees. Affordability. Individuals' responsibility must be augmented by measures to ensure affordability. We commend the committee for offering federal financial assistance to individuals and families with low and moderate income and those with high health care costs relative to their income to guarantee affordability. Eliminating disparities. We congratulate the committee for recognizing disparities in access to quality health care. No one should be discriminated for pre-existing conditions. No one should be discriminated for being low income, minority, disabled, or age. workforce. As the coverage grows, so must the healthcare workforce. Today, there are chronic shortages in almost every area of healthcare, from primary care physicians to nurses to long-term care workers. Healthcare reform, to be effective, must include a diverse, well-trained workforce that is working in the appropriate setting across the delivery system and is well distributed in both urban and rural areas. This is your moment to ensure that Pat DeJong and millions of other hardworking Americans do not have to wait any longer in America for quality, affordable health care coverage. The time is now. We cannot wait.
Thank you, Mr. Rivera. I wanted to apologize to Mr. Castellani because I said that you represented the Business Roundtable Institute for Corporate Ethics, and apparently it's just the Business Roundtable.
I am president of the Business Roundtable.
Yeah.
I am a member of the board of directors of the Business Roundtable Institute for Corporate Ethics. That's probably.
Oh, I see. Okay. Well, thanks for clarifying that.
Thank you, Mr. Chairman. I'm here on behalf of the members of the Business Roundtable, who are the chief executive officers of America's leading corporations. Collectively, they account for more than $5 trillion in annual revenues and 10 million employees, but most importantly, they provide health care for 35 million Americans. I appreciate the invitation to testify, and I share the urgency of this committee and the fellow panelists that health care reform must be addressed now. Today, I want to focus on three key messages. First, we need to get health care costs under control. Second, we must preserve the coverage for those 132 million Americans who receive that coverage from their employer. And third, we need a reformed insurance marketplace so that individuals and small employers can afford and find affordable coverage. Let me address the draft legislation that you have before the committee. First, let me thank you and the committee for moving forward on health care reform. We view that as very positive and necessary, and we want to be constructive in what we believe will work and what we believe will not. We support the provisions that reform the insurance market so that there are more affordable coverage options. The bill also includes a requirement that all Americans get health insurance coverage and includes auto-enrolling for individuals into S-CHIP or Medicaid if indeed they are eligible. We support both of those provisions and also support offering subsidies to low-income Americans who cannot afford coverage. The changes that you have included in the Medicare programs and other efforts to make our health care system more efficient are very positive. Medicare payments do need to be adjusted, and we'll provide the committee with comments on these and other issues. We do, however, have significant concerns about two major issues in the draft legislation and hope that the committee will consider some revisions. First, ERISA should not be changed if reforms are to be built on the employer-based system. The proposal before you would change some of the ERISA rules. For example, it would impose minimum benefit packages on our employees. Large employers design innovative plans, including wellness and prevention initiatives that have been tremendously successful in helping employees take greater control over their own health. And yet such programs, which we believe are critical to the success of health care reform, would be jeopardized by a new federally mandated benefit law. Second, we're very concerned about public plan proposals that would compete in the private marketplace. As large employers, we're concerned that our employees will suffer from additional cost shifting that come from inadequate government repayment to the providers. For that reason, we're concerned that the kind of cost shifting that we're dealing with now would be exacerbated. Further, the government plan could erode existing worker coverage if employees seek a subsidized, lower-priced public option. That would diminish the people in our plans and would leave employer-sponsored coverage with more expensive, more costs for both employers and employees. Innovation, which we think is the key to modernizing our health care system and getting our costs under control, benefits improvements, and how best to care for patients, we believe come best from the private marketplace. We need to preserve the energy and the commitment to improve our health care market, and we're concerned that government plans cannot do that as well as the private sector. We urge the committee to instead create even stronger rules to make the private insurance marketplace more competitive, and we want to help in that effort. Business Roundtable believes that the search for bipartisan consensus can begin by honoring the principles that we've outlined in our written testimony and by crafting reform that is consistent with the uniquely American principles that drive our economy: competition, innovation, choice, and a marketplace that serves everyone. On behalf of our members, we pledge to work with you and all the members of the committee to find workable solutions that let people keep what they have today in a reformed health care system that works better for everyone. Thank you.
Thank you. Mr. Shields.
Hello. Good afternoon, Mr. Chairman. My name is John Shields. I'm with the Lewin Group, and I have specialized over the years in estimating the financial impact of health reform proposals. We got your bill on Friday and immediately went about doing some preliminary estimates on coverage and the impact on provider incomes. Allison's going to help me with some slides. Are they up? All right. Well, I don't see them, but the first slide, the system that the bill would establish begins with, it'd be the next page, please. Next page. There you go. We have a new health insurance exchange. The exchange would provide a selection of coverage opportunities. Most of them are private coverage that we are familiar with, but it would also offer a new public plan. The impact that this program will have on coverage is going to be driven by the groups that you're permitted to enroll. The program would allow individuals, self-employed, and small firms, at least in the first year, to go through the exchange to obtain their coverage. In the second year, in the third year, the newly established commissioner would have the authority to open the exchange to firms of all sizes. The new public plan, we predict, will attract a great many people because the premiums in the public plan will be much lower than for private insurance. And because of that, we think that a great many people are going to be attracted to it. Let's discuss that a little bit. On the next slide, we show, to summarize some of the payment rates on the left side. You're using the Medicare hospital reimbursement methodology, and under Medicare, payments are equal to about 68% of what private payers have to pay for the same services. For physician's care, you pay about, well, Medicare pays about 81% of what private insurance pays. You're going to be adding another 5% to that, so we're looking at about 85% of private payers. And there's also, we also have some information here on what happens to insurance administrative costs. In the exchange, the public plan will not have to need an allowance for profits, and it will not pay commissions for brokers and agents. The next chart shows what happens to premiums. For family coverage, for the enhanced benefits package described in your legislation, in the private sector it would cost about $917 per family per month. Under the public plan, it would cost about $738 per family per month. That's savings of about $2,200 a year, and we think that is going to draw a lot of people into the public plan. On the next page. On the right-hand side, we have we illustrate what happens to coverage when the plan is open to all firms. The program would reduce the number of uninsured by about 25 million people. There'd be an increase in Medicaid enrollment of about 16 million people. But we'd find 123 million people going into the public plan. That's a reduction in private coverage of about 113.5 million people. That's about 66% of all privately insured persons. This, of course, is if and when the plan is open up to firms of all sizes. If it is limited to just firms of less than 10 workers, as in the first year, you still get a reduction of about 25 million people uninsured, still 16 million people with Medicaid coverage, but private coverage would drop by about 20 million people. The public plan coverage would be 29 million people. Next chart, please. This chart summarizes what happens to provider incomes under the plan. On the right-hand side, we have the scenario where all firms are eligible to participate in the program. Hospital margin, which is hospital profit, net income basically, would be reduced by about $31 billion because of that. That's about a 70% reduction in hospital margin. physician net income would go down by about $11 billion. That comes to, in terms of net income, that's an average of about $16,000 per year reduction in net income per physician. On the left-hand side, we show what's happening under the small firms, and this is really interesting because under this scenario, provider incomes actually go up. For instance, hospital margin goes up by about $17 billion. Much of this has to do with the fact that we'll have reduced uncompensated care. They'll be paid for services they were providing for free before. And there'll be new services they'll provide to newly insured people. The physician net income would go up by about $10 billion. And the increase in income there is largely driven by the fact that you are going to increase payments for primary care under the Medicaid program. That's that sums it up, and I'm out of time, so I'll turn it over to my colleague here.
Mr. Chairman and members of the committee, I want to thank you for the opportunity to testify about proposals to reform the U.S. healthcare system. I am here today on behalf of the National Coalition on Benefits, a coalition of 185 business, trade associations, and employers that have joined together to work with Congress to strengthen the employment-based system. The NCB supports healthcare reform that improves healthcare quality and reduces costs. The NCB recently wrote President Obama applauding his commitment to comprehensive, bipartisan healthcare reform. We expressed our shared view that a strategy to control costs must be the foundation of any effort to improve the healthcare system. I have included that letter in my written testimony. For many years, the American people have sent two clear messages to elected officials. First, Americans want to see change and improvements in both cost and access to health care. And second, Americans like the health benefits they receive through their employer. The NCB believes the American people are right on both points. We do need change. However, such change should not erode the part of the healthcare system that is working. The employer-sponsored model works well because it allows the pooling of risks and because group purchasing lowers healthcare costs, enabling those who are less healthy to secure affordable coverage for themselves and their families. ERISA and its federal framework allows employers to offer equal, affordable, and manageable benefits regardless of where the employees live and work, and without being subject to the confusing patchwork of mandates, restrictions, and costly rules that vary from state to state. Yet, as good as it is, the system is increasingly at great risk. As President Obama has said, soaring healthcare costs make our current course unsustainable. The National Coalition on Benefits completely agrees. Unfortunately, we are concerned that the legislative proposal released last week does not provide meaningful cost savings for the overall system. In an effort to expand coverage, cost containment has not received the priority it demands. For several years, employers have worked to make clear the issues that healthcare reform must properly address to preserve the employment-based system, control costs, and lead to our support. To date, we have not seen legislative proposals where each of these core issues have been adequately resolved. I will briefly discuss our concerns on ERISA, the employer mandate, and the public plan. If the objective is to build upon the employer-based system that successfully covers more than 170 million Americans, then employers must have the ability to determine how best to meet the needs of their employees. Legislation should not include changes to ERISA or other laws that would risk hurting those who are highly satisfied with the health care coverage they currently receive. The NCB opposes provisions that alter the federal ERISA law remedy regime. The existing structure encourages early, out-of-court resolution of disputes and provides a national uniform legal framework to provide both employers and employees with consistency and certainty. The draft of the legislation would replace the successful structure with differing remedy regimes depending on where the employers and employees obtain health coverage. All these differing bodies of law are likely to result in contradictory decisions about plan determinations and would expose employers who obtain coverage to the exchange to unlimited state law liability. In other words, these legislative provisions would weaken the employer-based system. We are also concerned about proposals that would limit the flexibility of employers at a time when our country needs employers to create jobs and invest in future growth. Employer mandates, including requirements to pay or play, are not the answer to the health care problem because they undermine our ability to address two key goals of health care reform: coverage and affordability. On the public plan, we do not believe a public plan can operate on a level playing field and compete fairly if it acts as both a payer and a regulator. A public plan that would use government-mandated prices would result directly in a cost shift to other payers, and thus would do nothing to address the underlying problems that make health coverage unaffordable for many. We already experience that cost shift today as Medicare, the largest payer in the United States, consistently underpays providers. In summary, we remain concerned about any provisions that would make health care more costly for employers and employees, destabilize our employer-based system of health coverage, or restrict the flexibility of employers to provide innovative health plans that meet the needs of their employees. As Congress moves forward to formal consideration of the legislation, we want to continue to work with all members of Congress to enact reforms that not only allow Americans to keep the coverage they have today if they like it, and for most Americans that means their employer-based coverage, but make it possible for them to count on it being there tomorrow when they need it.
Thank you, and thank you all. I'm going to start, and I'm going to try to get a lot in my 5 minutes here, so bear with me if you don't mind. Mr. Shea, you expressed concern about taxing health care benefits, and you know and you acknowledge in your testimony this came from the Senate, not from the President, not from the House, needless to say. My concern is that, a stated purpose of this reform is to let people keep what they have, and that to keep what they have, and of course that implies employer, not only for employer benefits, but whoever has a health insurance policy that they have. So, I mean, if you just want to tell me briefly what the consequences would be. I mean, I know everything's on the table, but this is something that I'm concerned about. Just briefly.
What was it that somebody said about some things are moving off the table? But we hope this is in that category. The main thing that would happen, it was to destabilize employment coverage, which, as I said, is exactly the opposite direction from where we need to go. Because it would change the relationship between employees and employers around this very important part of their compensation. Some employees who are younger might say, well, gee, I don't really need to be part of that group plan. I'm going to go off, and since it's now tax money. Secondly, it would penalize certain groups of workers because of their health status, essentially. We've looked at health funds. I'm
going to stop you because
okay.
I appreciate what you're saying, but I got to ask Mr. Rivera a question. He stressed the pay-to-play requirements for businesses, and of course, we get criticisms of this, and suggestion that it's going to hurt business. Why do you think the pay-to-play requirement is necessary for why do you think it's a good idea, basically?
Because we believe that at this moment, it's some of the employers who basically are providing health care are basically subsidizing those who are not providing health care. For example, on average, health insurance is about between $1,300 to $1,500 more for the cost of a family insurance, and those who don't provide health care coverage to their employees are basically on a free ride here. That's basically our perspective. Okay.
Now, what about the public option? You said you're supportive of it. Obviously, it's in the discussion draft. Are insurance market reforms enough to drive down costs and ensure coverage for all, or you think the public option is an essential piece of the reform?
We believe that it's an essential part of the reform, sir, and we believe that it will be a very important contribution to lowering the cost of health care. And basically, this is America, where we all can compete, and this is another way of competing to lower the cost, sir.
Okay. Mr. Shields, I'm going to you last here. I got about 2 minutes left. You criticized the public option, and just for purposes of full disclosure, the study you mentioned, my understanding, and tell me if I'm wrong, is it was completely funded by an insurance company. You said in your written testimony you're the senior vice president of the Lewin Group, and your group my understanding is your group is 100% funded by United Health Group, one of the largest insurance companies in the country. Is that accurate?
We are owned by United Health. We have a 36-year tradition of doing.
But it's 100% owned by United Health.
I'd like to finish.
Well, let me get to the next thing. You probably can respond to it.
Anyway, we were about 2 years ago, and at that point we were on but our work is completely independent. We have complete editorial control over our work.
But I mean, the group is 100% funded by United Health, right?
Well, we're a consulting firm. We're funded by the work we negotiate with the clients. So I work for the Commonwealth Fund. I work for Families USA. I've worked for Blue Cross Blue Shield.
But what about this study?
This study?
Yeah.
This study was done on our own nickel.
But who funded it?
No, well, we just did it on our own nickel. We did it out of corporate, our firm's overhead.
Did United Health directly or indirectly pay for it because they're funding you? I'm just trying to get an answer to that.
You could say it that way, but United Health did not review any of our materials before they go out.
Okay. I mean, the only reason I mention is our committee conducted an investigation of United Health, and we found that the company had incredible profitability. In 2004, their net income was $2.6 billion. 2005, it grew to $3.3 billion. 2007, it went up to $4.7 billion. Even last year, at the height of the financial collapse, the company's net income was $3 billion. And then in this Mr. Shields in 2000, I mean, not you, in 2005, the CEO of United Health, William McGuire, was the third highest paid CEO in the country, according to Forbes magazine. He resigned in 2006 after the SEC launched an investigation involving the backdating of stock options, but United Health gave him a severance pay of $1.1 billion, which was stunning to me. I mean, do you think it's appropriate for United Health to pay the CEO more than $1 billion severance?
I don't have, if I were at the pay level where I would even know this stuff, I'd be in a much different spot.
Okay.
We work for a firm that was bought by Ingenix, which is owned by United Health. We don't get involved in anything like that, and there's nobody in our firm who ever sees income of that type.
Okay.
You can only imagine how surprised we were when 2 years ago we were bought. But they quickly assured us that they wanted us to maintain editorial control of our work, to continue our 36-year tradition of non-biased, objective, nonpartisan work.
All right, thank you.
That's all I'm about.
No, I appreciate that. Thank you. Mr. Whitfield.
Well, thank you, Mr. Chairman, and I want to thank all of you on the witness panel for being with us today. We genuinely appreciate your testimony as all of us attempt to get through this legislation and understand as best we can what the ramifications and implications of the legislation will be. We hear a lot of discussion about the public plan, the public option, and I know some of you are opposed to it, some of you support it. What I hear most of all from members of the committee, the concern is that if you have a public plan, many people will leave the private plan, their employer plan, and go join that plan because the costs are lower, which is certainly understandable. But eventually, you can basically destroy the employer plans because everyone's going to leave, and then you're up with one big government plan. And maybe that's okay, except the Medicare system can be criticized in many ways, particularly because of the cost escalations. And I'm saying that because Medicare is basically a U.S. government plan, and if this public option goes the way some people will say, that's going to be a big government plan. And I make one comment. In 1965, when they started the Medicare program, the Congressional Budget Office did a forecast that in 1990 that plan would cost $9 billion. It turned out to be almost $200 billion by 1990. So that is an astronomical miscalculation. So, Mr. Shea, you represent the AFL-CIO?
Yes, sir.
Okay. Well, tell me, the argument that I made that if it's less expensive, more people are going to move over there and it's going to weaken the private system, does that concern you, or do you think that that argument has a merit?
Well, as I said, Congressman, we start out saying that we need to address cost containment, just like others on the panel have said. That's job number one. If we don't control these costs, nothing else is going to be done in healthcare. So how do you do that? Well, there are several ways to do it, but the public health insurance plan is one. You can calibrate the rates in the public insurance plan. This plan proposes Medicare rates. You could do Medicare plus 10%, or you could do halfway between private. That would all affect this. But the notion is to put some competition in an insurance market that now doesn't display any competition. What we have are really close relationships, in my view, between insurers and providers. And that's the problem that we have to change. It was what Mr. Conklin was talking about. We're just trapped by this. So there are other ways to do it, but this is what the competitive model is.
Okay, thank you. There are other ways to do it. Now, Mr. Reiser, would you make a comment to the argument that I put out there that people are making?
Yeah, the concern that we have about the public plan option is Medicare currently underpays, and there's a significant cost shift onto the private employers, which is a big problem in the current system. A public plan option, we believe, would exasperate that, particularly a public plan option as outlined in the proposal that would pay Medicare rates. That would just exasperate the system. The second problem that we see with it is if people do leave the employer pool, that is going to weaken our risk pool, lead to higher costs for the remaining employees, and over time will weaken and potentially destroy the employment-based system.
Yeah. Yes, sir, Mr. Riviera.
Yeah, one of the things that, for example, we have in New York State a healthcare plan which provides healthcare for healthcare workers in the greater New York metropolitan area, and we pay about $8,500 for family insurance. Upstate New York, where only one of the insurance companies basically dominates the market, we pay up close to $17,000. So basically the idea of the public plans is to come into markets where basically are concentrated by only one insurance company, and there's a case of Maine, New Hampshire, and you could see high-cost areas where basically the lack of competition that basically insurance companies don't come into those areas, and the cost of healthcare goes up.
Mr. Castellani, how do you pronounce
Castellani.
it? Castellani. I know the Business Roundtable is comprised of very large companies, but what are your views on the pay-or-play provisions of this bill?
Well, pay-or-play is almost an academic issue for us because, indeed, on the surface, all of our members provide health care, and we want to continue providing it. The problem that we see with the concept of pay-or-play is that we need to bring into the health care system all those people who are currently not covered or can't afford to be covered because we're paying for them through the kind of cross-subsidies that Mr. Reiser referred to. We do not see the merit of forcing companies to buy something that they cannot afford, particularly the small businesses. And so pay-or-play, we think, can be dealt with if we provide the kind of competition that both Mr. Rivera and I think all of us would agree on, but we think it is best provided through reforms in the insurance market. Because in addition to what Mr. Reiser said, that is, the public option plan exacerbates the cost shift. It potentially erodes our risk pool and leaves and causes younger, healthier people to leave, quite frankly, who can get a lower premium. But it also does something else that hurts what we all want and we all talk about, and that is we see much more innovation in terms of delivery, in terms of wellness, in terms of prevention, in terms of quality, in terms of information technology, the kinds of things that will reduce costs and increase quality coming out of the private sector. We're concerned that a government-run program, as we see now in Medicare and Medicaid, just doesn't have the ability to innovate, so we also lose out on the ability to gain from those innovations.
Thank you. I see my time has expired.
Ms. Capps, our Vice Chair.
Thank you, each of you, for your presentations. It's been a good panel. You waited a long time, many of you, because it's been a very long day of presentations and different panels on this topic of healthcare reform. I have questions for two of you because there's not enough time, only 5 minutes. My first question will be for Mr. Rivera with SEIU. In your testimony, Mr. Rivera, you expressed that individual responsibility must be augmented by measures to ensure affordability. It seems fair to think that our healthcare system should meet hardworking Americans halfway. For this reason, SEIU supports affordability credit for families between 133% and 400% of the federal poverty line. Why do you believe it's necessary to offer these credits for families up to 400% of the poverty level?
Well, part of the problem that we have is the incredible cost of healthcare these days. For example, in the case of SEIU, almost 50% of the members of our union basically live on very meager means, less than $35,000. So when you take into account, on one hand, the high cost of healthcare and the disposable income, you see that basically, in order to make it meaningful, you have to have subsidies.
So for you're talking about your workforce.
Yes.
Hardworking men and women with raising a family and trying to have a quality of life in this country, not at all luxurious, but still they're doing essential work in their communities, and they should have a decent healthcare system. And so you're wanting to provide that.
As a matter of fact, the overwhelming majority of Americans who don't have healthcare coverage are working people who make more money than to qualify to Medicaid, and are not all enough to qualify on Medicare. And then the question that they have,
which shows you one of the disparities, that the premiums are so expensive that you really, if you're going to have your own private insurance plan, if self-employed or whatever, you have to be upper middle class or wealthy in order to pay for it. And that's one of the major challenges that we face in this country right now. I'm sure you would say that. Are there some other protections? We're talking about middle class, right? Or at least what we want to consider as the middle class, the working class, the hardworking people who keep this country going, whether in small businesses or in large companies providing labor or providing management. What other protections do you believe are necessary to make health care more affordable for the middle class?
Well, I think
this is a big question, but I want to also move on to another.
I think the fundamental question that we have is that we're spending 17.5% of our gross domestic product in healthcare, and if we do not, and I think my colleague Mr. Shea was talking about, if we don't resolve the problem of the cost controls, we're not going anywhere.
I see other people nodding your heads. I mean, is this sort of a given? That this is one of the major challenges that, and one of the reasons that you're participating is because we need reform to deal with this in some aspect. I really appreciate that, and you are a very diverse group, I might add. I think there's quite a cross-section here, and that's interesting. I would like to now turn for the last couple minutes to you, Mr. Shields, just some particular questions about what you were talking about. Your analysis suggests that a public option can get lower premiums than private plans. Some of our colleagues are making come to the conclusion that this disparity, that a private plan is not even going to be able to compete with a public option. Does your model assume that private insurers and large employer purchases are simply price takers with no ability to add value or change behavior in a competitive market? In other words, is it so monolithic in that private world that there is no ability to compete?
Well, we don't conclude that they cannot compete. We conclude that there are only certain types of plans that could compete.
Mr. Shields, if you want to turn that on and bring it closer to you.
Okay. There are only certain types of plans that could survive, and those would be integrated delivery systems like some of the better HMO-type models. A lot of Americans...
What are you doing? You did that in the toilet?
Whoops.
Out of order.
I'm sorry, there's a little glitch over here, I think.
Fascinating glitch.
Let's not take that off my time either, okay?
I'd like to explain that, though, because
Please.
there are some key issues here. Right now, a lot of the insurers get price discounts with providers.
Right.
Having to do with the fact that they make volume discounts. They say to a hospital, I'll bring you all 100,000 of my people for their hospital care if you'll give me a break. Now, if everybody goes to the public plan, and the health plan, private health plan, only has 10,000 people left in it?
The public plan is not going to be able to offer that, is it? I mean,
But
that's pretty competitive.
I wanted to finish my point.
Sure.
My point is that if there's only 10,000 people left in the private insurance plan, then they're not going to be able to negotiate discounts that are as deep
And that's
as
the
what
only-
they can get today.
And that's the only way they can be competitive.
Right.
Wow.
There's,
I would hope that there'd be a lot more creativity within the private sector. And I will get to you, but you said I could have a little more time because of that terribly disruptive moment there. Anyway, maybe you or someone else would comment about some of the larger markets like Los Angeles, New York City, private plans bidding below Medicare fee-for-service levels. How do you factor that into the model? And then I'll open it up if there's time.
well, there are places where there are smaller disparities between Medicare and private. And then there are places where there's much larger disparities.
Well, that's a hint
So in
to
those
some of the
areas where
private
you have
plans.
large disparities, we get quite a bit of take-up. In areas where there's little disparity, it doesn't really show us very much of a change.
Another comment on this or the other? Question?
Just on the whole dynamic, I think what's important to bear in mind about the Lewin analysis is that it is based on the prices. Your point is just price taking. Employers, and you could ask people on this panel, employers make decisions based on more than price in healthcare. This is a very important.
Is that a valid point? May I ask for corroboration?
One more, and then I think we got to move on.
Okay. I would hope so, because I would hope that we'd have a little more creativity in the private market. We actually need that competition because this is too big for any one response. Many of us feel that way, and I think that's a feature of the public option, is that it will be competition and it will be a competitive marketplace. In my congressional district, it isn't competitive at all. It's rural, and there's only one private provider. So, this is a sorely needed situation. I'll yield back, Mr. Chairman.
Mr. Gingrey.
Mr. Chairman, thank you. Let me direct my question to Mr. Castellani of the Business Roundtable. Mr. Castellani, could you explain to us how the public plan proposals would undermine the private insurance industry that many Americans are very happy with? And I'm not, quite honestly, I've read some of your testimony, and I'm not sure where you are on this public plan proposal. In the interest of full disclosure, I'm concerned about it. So that's the reason for my question.
Yes, sir. What we're concerned about is not that it would undermine, although it would, the private insurance, but it would undermine our ability as employers to provide health care for our employees through the private insurance market. And it is for the reasons that we have discussed here, and it's primarily three. We do agree with competition. What Congresswoman Capps was addressing is what we think is part of the solution. We need greater competition. But that competition has to be on a level playing field. If a government plan exists and it has all of the elements of a private plan, except it is not required to pay its investors back a fair return on their investment, the taxpayers in this case, then it can and will, by definition, have a lower premium cost. So the first effect is we would lose people who could qualify and would move to that lower premium from our plans. As a result of that, they will tend to be younger and tend to be healthier employees. Our costs go up because we would lose that spectrum of our risk pool that allows us to provide an affordable product for all of our employees.
Now, Mr. Castellani, you're speaking from the perspective of the Business Roundtable.
From the payers, yes.
From the Business Roundtable.
Correct.
And we're talking about the payers and what they're probably 270 million lives covered through employer-provided health insurance. My numbers here say most of the 177 million Americans who have employer-based coverage say they are happy with the coverage they receive. And President Obama, God bless him, has promised to ensure that those folks can keep what they have. I think that's almost a quote. He likes the word folks. Those folks can keep what they have. I've heard him say it many times. Do you think that the public plan could lead to Americans losing their current coverage because of an unfair playing field that would be established by a public plan?
Yes, I think it runs that risk.
All right. Well, I tend to agree with you. Now, describe for the committee and for everyone in the room, what are some of the unfair aspects that could be attributed to a public plan that we are concerned about, that you're concerned about, that the Business Roundtable is concerned about?
Well, as I had answered previously, a lower premium cost would be attractive to some of our own employees for which we provide coverage now. If they leave the system, we have a reduced risk pool, and the nature of that risk pool, the nature of our employees, could leave us with a more costly and fewer number of lives to cover. The second thing that it does is, by its design in this draft legislation, it does not fully reimburse for costs. So another large player, in addition to Medicare and Medicaid, that does not fully reimburse for costs gives us a situation with, for example, you're a hospital. The government's not going to pay anymore. Medicare and Medicaid's not going to pay anymore. The uninsured can't pay anymore. There's only one person left paying, and that's the employers. So it exacerbates the cost shift, makes our costs potentially greater rather than what we're all trying to achieve, which is more affordable health care at lower cost trajectories than we have now. The third thing it does is it hurts us in the long term, and that is that fundamentally government programs are not able to innovate at the kind of rates and with the kind of creativity that we see in the private sector with competition, and we need that kind of innovation to bring down the trajectory of costs. So it hits us three ways in raising our...
Well, I had one more, Mr. Chairman. I can't see the clock. I don't know how...
I know, it keeps going off. Go ahead with it.
Okay, all right. Thank you, Mr. Chairman. I appreciate your indulgence. Just one more question, Mr. Castellani. Under this bill, under this draft proposal, a tri-committee draft proposal, did you see anywhere that describes what would happen if the public plan did not set the premiums and the cost sharing high enough to cover its cost? Was there a provision that describes what happens if the public plan, if their reserves are not high enough, for example, and indeed, was there anything in the draft that describes where those reserves would come from and how they would compare with the reserves that were required of the private insurance, health insurance plans that they're competing with?
I don't believe they were, at least in my reading of it and analysis of it, they weren't specified. They say there are reserves will be provided for. But the one thing that is missing, even whatever levels they would be provided at and the networks would be provided at in the public plan, the one thing that is missing is a fair return on the people who invest in the capital that allows that public option to exist. If you don't have that, you always have a cost advantage.
Yeah. Well, I thank you very much, and I'm sure my time has probably already expired. Mr. Chairman, thank you for your indulgence. Sure. I appreciate it, and I yield back.
Thank you. I think that's the end of our questions. Thank you very much. We appreciate it. I know it keeps getting later. We have one more panel, but you may get, as I think you know, you may get some additional written questions within the next 10 days, and we'd ask you to get back to us on those. Thank you very much. And we'll ask the next panel to come forward. I think our panel is seated. We'll ask those who are talking in the back to please leave the room. Sirs. Thank you. And I know the hour's late, but we do appreciate your being here. And I'm told we may also have another vote, so we'll see. We'll try to get through your testimony. This is the panel on insurer views. And beginning on my left is Howard A. Kahn, who is Chief Executive Officer for LA, I assume that's Los Angeles Care Health Plan? LA, okay. Karen L. Politz, who's Project Director for the Health Policy Institute at Georgetown Public Policy Institute. Karen Ignani, who is President and CEO of America's Health Insurance Plans. And Janet Troutwine, who is Executive Vice President and CEO of the National Association of Health Underwriters. And I don't think I have to tell anyone here that we try to keep it to 5 minutes, and your written testimony will be included complete in the record. And I'll start with Mr. Kahn.
Thank you, Chairman Pallone. Members of the committee, thank you. The need for national health care reform has never been greater. As the CEO of LA Care Health Plan, America's largest public health plan, I am here to provide information about our model and how a public health plan option has worked in California for more than a decade. LA Care is a local public agency and health plan that provides Medicaid managed care services. We opened our doors in 1997 as the local public plan competing against a private health plan, HealthNet of California Incorporated. LA Care strongly supports the concept that public plans can provide choice, transparency, quality, and competition. LA Care competes on a level playing field against our private competitor. Plans must have enough funding to ensure provider payments and operate under the same set of rules. LA Care has always been financially self-sustaining and has never received any government bailout or special subsidy. LA Care serves over 750,000 Medicaid beneficiaries and has 64% of the Medicaid market share in Los Angeles. The competition between LA Care and HealthNet has resulted in better quality and system efficiencies. For example, as part of our efforts to distinguish ourselves in the marketplace, LA Care attained an excellent accreditation from NCQA, validation that it is possible to provide quality care to the poorest and most vulnerable in our communities. There are 7 other public plans like LA Care in California providing health coverage to Medicaid beneficiaries. In all of these counties, the public plans compete against private competitors. 2.5 million Medicaid beneficiaries are provided health services through this model. California has other public plan models as well. Congresswoman Eshoo, a member of this subcommittee, is very familiar with the enormously successful county organized health system which she and I helped create within her district. Our provider network includes private and public hospitals and physician groups, nonprofits, for-profits, federally qualified health centers, and community clinics. Our subcontracted health plan partners include some of the biggest private health plans, Anthem Blue Cross and Kaiser Permanente, as well as smaller local plans. In addition to Medicaid, LA Care operates a CHIP program, a Medicare Advantage special needs program, and a subsidized product for low-income children. What makes LA Care a public health plan different? LA Care conducts business transparently. We are subject to California's public meeting laws, so all board and committee meetings are open to the public. LA Care answers to stakeholders, not stockholders. Its 13-member board includes public and private hospitals, community clinics, FQHCs, private doctors, Los Angeles County officials, and enrollees. Our enrollees actually elect 2 of our board members, resulting in a strong consumer voice. Part of our mission is to protect the safety net. When Medicaid managed care began, there was fear that FQHCs and public hospitals would lose out. Through several strategies, over 20% of LA Care's enrollees have safety net providers as their primary care home. In Los Angeles, large numbers of people will remain uninsured under even the most ambitious health care reform proposals, and the safety net will continue to need our support. Local public plans like LA Care protect consumer choice. Since we started, 3 private health plans serving this population in Los Angeles have gone out of business. LA Care's stability has ensured that Medicaid beneficiaries continue to have continuity and choice. Local public plans raise the bar on performance and quality in their local communities. LA Care offers a steady calendar of provider education, opportunities that improve provider practices and quality of care. Our Family Resource Center serves over 1,200 people a month, most of whom are not our plan members. While defining a public plan option is still underway, we recommend against creating a monolithic national public plan. Healthcare is and will continue to be delivered through local markets, which vary in terms of population and competition, infrastructure, community need, and medical culture. California recognized years ago the need to lower costs and improve quality, and developed local plan options for Medicaid that have been supported by each successive administration, both Democrat and Republican. With regards to the health insurance exchange, LA Care supports allowing states to create their own exchange. We appreciate the recognition that Medicaid beneficiaries have special needs and so are not included at first. However, we strongly recommend excluding Medicaid beneficiaries completely, as they are among the most vulnerable to care for and present unique challenges. California's local public plans are a successful local model that should be considered. Let's build on what's working in healthcare and focus on fixing what's broken. Thank you.
Thank you. Now, let me mention that we do have votes, but I'd like to at least get one or possibly two of the testimony in. So let's see how it goes. Ms. Pollitt's next.
All right. Thank you, Mr. Chairman, members of the committee. First, I'd like to congratulate you on the Tri-Committee draft proposal. It contains the key elements necessary for effective health care reform, and this time I'm sure you're going to get the job done. The proposal establishes strong new market reforms for private health insurance with important consumer protections, a minimum benefit package, guaranteed issue, modified community rating, elimination of pre-existing condition exclusion periods. These rules apply to all qualified health benefit plans, including those purchased by mid-size employers with more than 50 employees. Today, mid-size firms have virtually no protection against discrimination when a group member gets sick. Premiums can be hiked dramatically at renewal, forcing them to drop coverage, and with no guaranteed issue protection, finding new coverage is not an option. I commend you for not including in the bill exceptions to the employer non-discrimination rule that would allow employers and insurers to substantially vary premiums and benefits for workers through the use of so-called wellness programs. Clearly, wellness is an important goal, but ill-advised regulations issued by the Bush administration cynically hid behind it to allow discrimination against employees who are sick through the use of non-bona fide wellness programs that penalize sick people but do nothing else to promote good health. Another good feature of the Tri-Committee bill is the requirement of minimum loss ratios of 85%, which will promote better value in health insurance. The bill grants broad authority to regulators to demand data from health plans in order to monitor and enforce compliance with rules. And it creates a health insurance ombudsman that will help consumers with complaints and report annually to the Congress and insurance regulators on those complaints. Another key feature in the bill is the creation of a health insurance exchange, an organized insurance market with critical support services for consumers. The exchange will provide comparative information about plan choices and help with enrollment, appeals, and applications for subsidies. The exchange will negotiate with insurers over premiums to get the best possible bargain, and importantly, consumers and employers who buy coverage in the exchange will also have the choice of a new public plan option. I know you've talked today about the cost containment potential of such an option. It's also important that a public option would offer consumers an alternative to private health plans that for years have competed on the basis of discriminating against people when they are sick. Just last week, your committee held a hearing on health insurance rescissions that discussed people who lost their coverage just as they started to make claims. And at a Senate Commerce Committee hearing yesterday, a former officer of Cigna Insurance Company testified on common industry practices of purging employer groups from enrollment when claims costs get too high. I would like to submit his testimony for your hearing record today. When consumers are required to buy coverage, having a public option that doesn't have a track record of behaving in this way will give many peace of mind. And I left the rest of my statement in the folder. Isn't that terrible? There we are. I got it. I'm so sorry. Second, a public plan will promote transparency in health insurance market practices. In addition to data reporting requirements on all plans, with a public plan option, you will be able to see directly and in complete detail how one plan operates, and if private insurers continue to dump risk after reform, it will be much easier to detect, and sick people will have a secure coverage option while corrective action is taken. Mr. Chairman, in my written statement, I offer several recommendations regarding the draft bill and will briefly describe just a few of them for you now. First, the benefit package. The benefit standard in your bill does not require a cap on patient cost sharing for care that is received out of network, and it really needs one. Also, the benefit standard does not specifically reference as a benchmark the Blue Cross Blue Shield plan that most members of Congress enjoy. Many have called on health reform to give all Americans coverage at least as good as what you have. It's not clear whether your essential benefits package meets that standard, but if it doesn't, it should. And if that raises the cost of your reform bill, it will be a worthwhile investment to raise that standard. Over the next decade, our economy will generate more than $187 trillion in gross domestic product, and we will spend a projected $33 trillion on medical care. The stakes are high, and it is important to get this right. Second, rules governing health insurance must be applied equally to all health insurance. As drafted in your bill, some of the rules that will apply in the exchange might not apply outside of the exchange. Further, there's no requirement that insurers who sell both in and out of the exchange to offer identical products at identical prices. If the rules aren't parallel, risk segmentation can continue. As an extra measure of protection, the Tri-Committee bill provides for added sanction on employers if they dump risks into the exchange, and similar added sanctions should apply to insurers. Another problem with non-parallel rules is the exemption for non-qualified health benefit plans and limited benefit policies called accepted benefits. Healthcare reform is your opportunity to end the sale of junk health insurance, and you should do it. And finally, Mr. Chairman, with regard to subsidies, the bill creates sliding scale assistance so that middle-income Americans with incomes up to 400% of the poverty level won't have to pay more than 10% of income toward their premiums. But as charts in my written statement show, some consumers with income above that level could still face affordability problems, especially those who buy family coverage and baby boomers who would face much higher premiums under the 2-to-1 age rating. I hope you'll consider phasing out the age rating and also setting an affordability premium cap so that no one has to spend more than 10% of income on health insurance. Thank you.
Thank you. I don't want to cut you short, Ms. Ignani, so you can all wait until we come back. Well, hopefully we won't be too long. I'd say, what, 20 minutes or so? Thank you.